Good morning, everybody. My name is John Riggins Jr. Today I'm giving my senior lecture. So I've been thinking about this since my first year starting a residency here. I remember seeing the senior lectures at the end of my first year, and they were so encouraging to me. They gave me so much feedback. I learned so much throughout the years, and this is just going to reflect some of my passions that I've been thinking about for the last couple of years. Healing the wounds, a common reason that we all end up going to medicine, a common reason that I really want to go into medicine, a common reason that we all chose a career in the healthcare field. Learning how to heal, how to alleviate suffering of others from mental, physical, and emotional trauma. This has been something I've been thinking about for so long, especially all that we've been going through these last couple of years. This last year, I've come face to face with mortality over and over again, watching the news, not only in terms of police brutality and violence, but through the COVID pandemic. Reconciling our wrongs. Whose wrongs, we might ask? Society, us as professionals, us as individuals. As I thought about what I wanted to do, this topic just continued to pull at my heart. It's been one of the biggest motivations for me to pursue a career in medicine ever since I wanted to be a doctor when I was younger. My only desire was to really serve my community, to really make a difference, to address the health disparities that we see. And throughout it all, I've come to this topic. So there's a trend today in our society to want to be woke, a trend today to really want to pursue social justice, to speak about it, to go to protests, to take action, especially with Facebook and social media. We've been seeing it a lot. We've been posting a lot about it, and a lot of people have been out there really being activists now. But being woke takes a lot of action. It takes a lot of courage. It takes a lot of commitment. It's bigger than just kind of writing quotes. It's bigger than just being out there posters. It's really like a mind change. It's really working on your mind, on your heart, and your soul, and really reflecting on everything we're going through. The last couple of months, I've seen a really big focus on police brutality and violence against Black and brown people. But something that's ignored was an elephant in the room. I started to think about the healthcare profession, our medical history. How have we contributed to the health disparities that we see every day in our emergency department? So today, I'm going to shed light on it, and we're going to bring this elephant into the light for sure. Okay. So this has been my work home for the last 4 years, Kings County, SUNY Downstate. You're walking to this in the emergency department, really busy, you're tired. And these are some of the chief complaints you get when you open up your charts. My sugar is high, med refill, hyperglycemia, doesn't take meds. My blood pressure is high, non-compliant with blood pressure meds. I'm coughing and my chest hurts for a week. Diagnosed with pneumonia, did not pick up prescriptions. And this might pop up in your head. Compliance alert, non-compliance. This is how you might be feeling when you see something like this. Why didn't they just take their medication? Then they wouldn't be here. Then there would be one less patient to see. You might be feeling frustrated. You see other sick patients. You have patients coming in with high blood pressure, high sugar. You're wondering, why didn't they just take their medications at home? This might be your face as well. Just tired, exhausted after 6, 9 shifts of DOMA, right? You feel like this is what your patients are thinking. You're trying to give them the medication to help them, and they just do not want to take it. Hippocrates said it is more important to know what sort of person has a disease than to know what sort of disease a person has. And I think it's really important to keep in mind as we think about this. After you speak to your patients, you learn a little bit more. A 26-year-old that couldn't get an endocrine appointment for 6 months. The patient tells you, I can never get an appointment with my doctors. My blood pressure is high, I feel dizzy. The patient tells you, I've been taking my blood pressure meds every day. I've been telling my doctors and they've not put me on any other medication. It's just not working. I'm coughing and my chest hurts for a week. You realize that the patient went to pick up the prescriptions, but they couldn't afford it. They told their doctors they didn't have insurance and the medications were still sent to the pharmacy. So you might still feeling like this for your patient. Our empathy is triggered a lot of times when we hear the struggles of our patients and the social circumstances which we are hindering their medical care. You might start to see our patients as somebody who needs us and requires our saving. You might develop a savior complex. We need to think about whether our intentions and interventions are more focused on us and not on our patients. Often in the media, healthcare providers are presented in a way which makes it a very appealing profession to those of us who want to serve and help people. Think about the approach that we sometimes have with our patients. Is practicing empathy enough to dismantle historical wrongs and the mistrust that it has created? Should our patients blindly trust us because of our title and position? What have we truly done to earn the trust of our patients? What have we done to lose the trust of our patients? The savior complex, empathy without borders. What is the savior complex? It centers on the helper, not the helped. What are we thinking about when we're actually telling our patients what to do? When we're actually prescribing a medication? Are we centering on something that makes us feel good about ourselves versus what's best for our patients? Are we assuming that the helper knows what is best, often without even hearing the direct concerns of our patients? Do we acknowledge the deep injustices through decades and centuries that we have perpetrated against these patients? Do we do anything to give power to the people that we say that we want to help the most? So I've seen this picture many times. It's been coming across that, we are heroes, but we need to change this paradigm. Not saying that we are not heroes, but we have to learn that our patients are beautiful, complex people that can teach us as much as we can teach them. Has the trust been broken between us as healthcare providers and our patients? Let's explore a little bit of our medical history. So we have to acknowledge that we may be perceived by the historical wrongs of healthcare providers in the past. The responsibility is upon all of us to acknowledge, address them, and reconcile those wrongs. As part of the healthcare system, we all have a part in creating these health disparities, and we can have a part in rebuilding back that trust and closing the health disparity gaps. So as much as we want to be seen as the heroes, some of our patients might see us as this picture right here. This is Dr. Sims, somebody whose statue was outside of Manhattan, revered, yet he operated on these women, without any anesthesia at all. He tortured them over and over with many surgeries to perfect obstetric and gynecology techniques, never acknowledging them. This has come out later in history, and now some of the statues are being torn down. We have to acknowledge that these patients, Lucy, Anarcha, and Betsy, were operated on several times. Anarcha alone had over 30 surgeries done on her without any anesthesia. We know about the Tuskegee experiment that came to light years after they already killed and injured many Black men around the country. A lot of the medical literature and research we use do not end up using underserved patient populations to gather data. Is this due to a lack of knowledge about the importance of research? Or is it now deeply seated mistrust in these communities to now want to participate in any medical research? So I looked at one of these studies, it was back in 2016, that basically showed how false beliefs about biological differences between races does influence treatment of pain. This was done in 2016, and they looked at medical students and residents and what they believed about pain and differences between Black and white patients. There's a big price paid for the birth of what we call modern gynecology. So let's look at some of the infant mortality rates and the maternal mortality rates. This is my neighborhood in Brooklyn. And yes, we've definitely seen that here we've had patients that actually died during childbirth. If you look at it, Black women had around 41 out of 100,000 births, they died. And the infant mortality rate was way higher in non-Hispanic Black women, Black babies, I should say. So let's not only look at the graphs, because graphs are just numbers. Let's take a look at some of the people, some of the faces of the people that died. This right here, this is Dr. Shanice Williams. She died in November 2020. She was a fourth-year pediatric chief resident who died 4 days after giving birth due to complications from preeclampsia. This is Miss Amber Rose Isaac, who died after giving birth. She had difficulty of getting an appointment for OBGYN in the months before her death in New York City. This is Kyra Johnson. She died after internal bleeding several hours after a routine C-section. This is Dr. Shalone Irving. She was a CDC epidemiologist who died in 2017 after giving birth. She focused on addressing structural inequalities throughout her career in the CDC. And this is Miss Yolanda Kadima, who died 3 days after giving birth with a routine C-section delivery. It's always important to just put faces with the statistics that we like to look at. Let's talk about a nurse named Shirley Brown and Dr. Edgar Horger. I learned about this recently when I was watching Netflix, a documentary about the crack epidemic. So they spoke basically about how a lot of Black women patients who are in the obstetrics unit began getting drug tested. This was a policy started by this nurse, Shirley Brown, down in South Carolina. And they drug tested mostly Black women, right? And they started passing these names on to the police department. So a lot of these women were arrested after giving birth and taken in, right? Instead of being helped, they were just drug tested without their permission and arrested. And this doctor and this nurse placed those policies into place in the hospital. So think about it sometimes when we think our patients are lying to us. Do they have good reason to lie to us sometimes when these kinds of things happen? This happened in around 1990, 1991. So it's not that long ago at all. Think about Henrietta Lacks. She's a Black woman whose cancer cells are used around the world for biomedical research. She died from cancer at a young age. Her cells were taken from her without her permission, and it's used in research around the world. This has only come to light more recently, and the family has never gotten any of the money. A lot of these companies are making billions of dollars off of her body and her sake. So they had some new articles in New England Journal of Medicine, Beyond Tuskegee, the vaccine distrust and everyday racism. It's something that's been coming up in the news about why people don't want to get COVID vaccination shots, despite the research. All right, let's think about everything we've seen so far. Let's think about all the distrust that has been developing over decades. Not only the Tuskegee experiment, it's been happening for centuries since this country has birthed. And healthcare providers in the healthcare system has participated in the distrust. I've read another article called Understanding African Americans' Views of the Trustworthiness of Physicians. And these were some of the determinants and consequences of trust in physicians that they brought up. So trust, some of the determinants they brought up were interpersonal competence, technical competence. And with those consequences, they facilitated care seeking, they promoted patient honesty, and it basically enhanced adherence. Some of the things that caused distrust was also the interpersonal incompetence, technical incompetence, focus on profit, racism, expectation of experimentation. So let's speak about a topic called structural violence. It was a term coined by Johann Galtung in the 1960s, which basically describes social structures, economic, political, legal, religious, and cultural, that stop individuals, groups, and societies from reaching their full potential. These excluded marginalized populations from adequate healthcare privileges, technology, research that led to distrust and healthcare disparities today. Every time we don't treat a patient's pain properly, every time we don't give our patients appropriate referrals or timely access to specialists, every time we don't believe our patients, it perpetuates the pre-existing cycle of structural violence against our community. A lot of the focus of structural violence has been placed on the police departments, but we must recognize that the healthcare system has been part of the structural violence leading to social disparities that we see today in the creation of our country. We have to start using our community's resources. This is 3 blocks from my house. This is the SOS organization. They work to stop gun violence. They have a lot of these signs up that you might see where it's don't shoot, I want to grow up. They do a lot of community advocacy. Right, these are all the protests that we've been going through, right? You see a lot of signs, people jumping out. We have to tap into this power if we want to make change. There have been a lot of protests throughout the years against violence, against Black and brown bodies, and oppressive white supremacy in this country. We've had some of our own protests here at SUNY Downstate in Kings County. We have advocated our institutions against the injustices that are damaging to our communities minute by minute, day by day. But what we also have to acknowledge and bring to light is a role of the healthcare system that has brought harm to Black and brown communities in a powerful way. So we have to build a partnership with our patients. Yes, we have to work as a team. We have to build trust, collaboration, efficiency, and planning. We have to change the paradigm of the doctor-patient relationship. So a lot of times the paternalistic model is in place. I decide for you. I'm telling you what to do. We have to move over to the interpretive model and the deliberative model, where I give you the facts and help you to find your preferences. Ask about what your greatest concerns are. I can also tell you my preferences after I address your concerns as well. We have to change this decision-making dogmas if we want to regain the trust of our patients, right? We have to move from just giving our opinion and giving information to information and opinion flowing between the doctor and the patient. Should this be our relationship with our patients, or should we shift to a different paradigm? We should take the patient-centered approach in advocacy. How do we become allies for our patients that advocate for their well-being while trying to avoid a savior complex? We can improve communication. We can build better healthcare teams, educate our patients and educate ourselves about issues concerning our patients. We can locate resources in the community and the hospitals that can help our patients as well. We can use the families as well. We can review treatment options for our patients. And what's at stake? Our patients, our community members, our babies, our future. This is Devell Gardner Jr. If you guys remember from last July, he was killed at a barbecue in a Brooklyn shootout, July 2020, while sitting in a stroller. What's at stake here? If you look at the Black median household income, it trails other races over the last couple of decades. Racial and ethnic minorities are less satisfied with the healthcare they receive. If you look at this graph on the left, proportion of people who believe they would receive better healthcare if they were of a different race or ethnicity. US incarceration rates are way higher in Black and Latino groups. Black women are 3 times more likely to die after giving birth. Black men and Black women have shorter lifespans, right? And the percentage of households that are food insecure are a lot higher in marginalized communities. So the question comes down to, how can we reconcile this? How do we rebuild the trust between healthcare providers and our patients? Become true students of our history. I recommend everybody Medical Apart. There's a book I read about 10 years ago when I did a program that focused on health disparities. And it really opened up my eyes to some of the things that were going on. We speak a lot about Henrietta Lacks. We speak a lot about the ski experiment, but there are so many other atrocities that happened throughout our medical history that we should know about. The only way we can make true change is if we know our medical history. We have to read articles, read historical texts, magazines, and journals. The only way to not repeat history is to study it. We have to take a patient-centered approach. There is no simple solution, but it can begin with a patient-centered approach. Our patients should be at the center of our healthcare system, not a bystander. Communication with our patients is the first step needed to begin rebuilding trust between us and the patients that we serve. Patient satisfaction rules 1 to 3 in the Medicaid.gov organization all have to do with communication with our patients. Speak with our patients about their worries, concerns, and fears. Listen to our communities about what issues they feel need to be addressed. Attend community board meetings, rallies, and protests in the community. Let's acknowledge our wrongs. We must first acknowledge that we have played a role in a system that has harmed Black and brown bodies. We have silenced our patients. We have ignored the injustices that plague our communities. It is an ugly truth, and it is one that is hard to swallow. It is one that makes us uncomfortable, but the stakes are too high for it to be ignored. It might have not been intentional, but we are now responsible to correct it. Throughout the development of our healthcare system, there's been systemic sterilization of minority women, systemic rejection of diverse populations into the healthcare fields, and segregation of our hospitals. If you read this letter to the left, this was in 1959 to a person that was applying into the medical field, and they were rejected solely based on their race. Right? These were signs that were in the 40s and the 50s where people were sent to segregated hospitals. We have to develop, join, support organizations focused on creating inclusive, diverse, and equitable environments. We have to advocate at a local, state, and national level for our communities. We must advocate with and for our patients and communities. We cannot afford to stay silent with the injustices that we see on a daily basis. If we continue to turn a blind eye, the cycle will never break. In the past, our profession's silence has cost us and has lost us the trust of the people that we serve. Many researchers have studied how accountability and patient safety are intertwined within our healthcare system. In Aveling et al., the article on the left, the authors researched what elements and factors affect an individual's accountability in relation to patient safety. They concluded that the individual is not only influenced by his or her own moral compass, but by the organizational culture of the healthcare enterprise. In other words, although we as individuals want to be just and good and moral, our surrounding structure, policies, institutions can influence and perpetuate structural violence against the communities we serve. In Bolson et al., the authors explored why whistleblowing is necessary in our healthcare system. and how we need to shift the healthcare organizations' cultures to accepting and encouraging whistleblowing when wrongdoing occurs. Whistleblowing is essential to stay transparent and end organization and gain the trust of the patients that we serve. Accountability. We have to hold ourselves, our colleagues, and our healthcare system accountable for the historical and the present wrongs against our communities. We have to take these steps. We have to be honest with ourselves. We have to acknowledge the wrongs. If we want to truly be awake, we just have to open up our minds to it and just swallow the hard truth. We have to value others, value each other, value our patients in our communities. We have to keep records of the things that we've done. We have to be transparent, right? We have to take responsibility for these things and do the right thing. And we have to act promptly with care. We have to utilize our community resources. There are plenty of organizations like CAVI and Save Our Streets who are working with the community and in the community to improve our community's overall health. How do we help to empower our communities and utilize the strengths of the community to benefit our patients? How do we work against individual and systemic injustices in a multifaceted approach to improve the overall health of our communities? Our specialty and department is the gateway to the healthcare system for many of our patients, including the most vulnerable and those most discriminated against in our healthcare system. We have the opportunity and the duty to fight for the rights of our patients. Every day, we have the chance to regain the trust of our most vulnerable communities. It's up to each of us to close the gap in healthcare. It's up to each of us to advocate for our patients. It's up to each of us to work in partnership with our patients. It's up to each of us to become knowledgeable and well-read in our medical history. We have to heal the wounds of the patients that we have not fairly served and still do not fairly serve. We have to hold ourselves accountable for the wrongdoings of our profession. And we have to utilize our community resources to help build sustainable change. So in summary, the healthcare system has a deep history of injustice against marginalized communities in this country. The injustices and structural violence of our healthcare system have caused the distrust between us and our patients. We as healthcare professionals must work to rebuild this trust. We must avoid developing a savior complex. We should build a patient-centered model to serve our patients. We should utilize our community resources to improve our community's health. We should always advocate for our patients. And our field of emergency medicine gives us the privilege to reconcile our wrongs on a daily basis. Thank you guys very much. Special thanks to Dr. Willis, Dr. Hassel, and Dr. Gore for their feedback. I want to thank my fiance Regine, my family, my friends, my amazing classmates, all of my residency family and attendings, the hospital staff, and my patients. It's been a pleasure. I'm really going to miss this place. Really sad to be leaving, but I've learned a lot here. These are my sources. Thank you guys very much.